It is my pleasure to welcome Dr. Cliff Rosen to our Science Cafe stage this evening. We're thrilled to have him. And as many of you may know, Dr. Rosen is a physician scientist who is currently serving as the director of the Center for Clinical and Translational Research at Maine Health. He's a board certified physician in internal medicine, endocrinology, diabetes, and metabolism. And he's also a professor of medicine at Tufts University School of Medicine. Many of you here today may recall that he is also the founder and former director of the Maine Center for Osteoporosis Research and Education. He's authored more than 300 peer-reviewed publications and maintains an active clinical research laboratory. One of the other things that Dr. Rosen is really passionate about is addressing the health equity and disparity issues that are faced by rural populations like those here in Maine. And so tonight we're excited to have a conversation with him about some work that he and his colleagues are doing to really figure out how rural populations benefit from participating in clinical research. And so with that, Dr. Rosen, welcome. We're thrilled to have you with us this evening, and we look forward to getting started.
Thank you very much, Jerry, and it's a pleasure to be here. I sort of wish I was up there in person, but I was just there a couple of weeks ago. So I'm going to talk about the interface of rurality with research opportunities. And I just was thinking on walking the dog a few minutes ago that it was 30 years ago that we initially started a study in Greenville, Maine at C.A. Dean Hospital looking at vitamin D supplementation through milk products to prevent bone loss. And the reward at that time for participating in that study of rural elderly women was that they got a trip to Bangor from Greenville, and they got to have lunch with Sister Norberta. So things have changed a little bit in 30 years, but I'm going to try to provide you with the landscape of our efforts and where we think we're going. So without further ado, I just thought that this little cartoon sort of represented how other people visualize Maine. I never thought of Maine as being a flyover state. In fact, it takes a lot of intercontinental transatlantic flights and they land there. But yes, it's within the category of the other flyaway states. And as a rural state, it sometimes gets considered in the realm of politics. I'm not going to talk about the political aspects of flyover states, but I am going to tell you that rurality is a dominant feature of the population in Maine, and nothing that should surprise anybody on this call. But I wanted to give you some overview in terms of what we face when we think about rural Maine. And in general, as you know, Maine is the oldest state in the country, and that's the first line of our grant applications almost exclusively to almost every NIH institute, is that Maine has the highest population of individuals over 65. They also have a very substantial population of individuals not attaining high school diplomas. And we're getting to be an obese epidemic in Maine as well as in other areas. Of course, it's been centralized in the southern United States, but as you can see from these diagrams, that overweight individuals in Maine are greater than overweight individuals in the United States. In addition, the prevalence of conditions related to obesity, including asthma, are greater in Maine. So these data are from the CDC in Maine, and they did this interesting analysis where they took a portion of the population and equalized each region's population numbers. So they took a certain number of individuals. Obviously, southern Maine has 750,000 people, and there's no comparison. But what they did is take a portion of that population and equalized it to hospital districts. So southern Maine, central Maine, and then eastern Maine. And these were, as you know, catchment areas. And what you can see in this slide is that percent of people living below the poverty level is highest in the northeastern section. I guess no big surprise. And their health indices are much worse. in the northeastern than in southern Maine. And of course, the central area is halfway in between. And again, diabetes and asthma prevalence are greater. In addition, COPD and cardiovascular hospitalizations are greater in the northeastern section. So what is rural? What does it mean by calling ourselves living in a rural area? Well, surprise to everybody that there's lots of definitions for rurality. And I just wanted to show you something on the web if you're interested. Are you a rural individual? You could go to this RAHI hub and find out, or you can look at these RUCA codes and see people around the country who's rural and who isn't. So RUCA codes were set up by the United States government, and the idea was to classify people into urban, near urban, rural, but close to urban areas, and then not close to urban areas, really considered rural. And it doesn't take much to see that in the upper right-hand corner, Maine is predominantly a rural state. But you'd be surprised how many individuals you might think are living in rural areas are not really considered that by the RUCA code. And the reason we know this is when we do NIH population studies, or when we enroll individuals, the RUCA codes come up, and we try to target rural individuals for research studies, predominantly because NIH wants us to be able to recruit in rural areas. And so we have to plug in their location, and then a RUCA code comes up. And as you'll see, the RUCA codes provide a lot of insight into research that's already been done about rural individuals. But sometimes what you think is rural is not rural. You can see that the predominant areas in northern and eastern Maine are rural, and I'm sure Bar Harbor's on that list. And I'll be talking to you about that shortly. But in some sense, it's always a little artificial. But this is some data from the CDC, National CDC published, which shows that rurality is associated with greater mortality, and that's age adjusted. And you can compare those in the red line, the rural communities, with those in urban counties. And this is done through RUCA codes. And in addition to greater rates of age-adjusted mortality, there's also greater rates of poverty. So one of the projects that we've been intimately involved in at NIH, with NIH, has been the N3C study. And the reason for that is related to the recent COVID pandemic, which continues to persist in this country. And we joined the National COVID Cohort Collaborative. So this is a large NIH-funded study to individual investigators in large networks to try to deposit data about COVID infections, long COVID, and treatment options. And it's called N3C, although it's the National COVID Cohort Collaborative. And currently, there's about 15 million data entry sites. These are de-identified data on individuals that were hospitalized with COVID or have developed COVID infections. And at MaineHealth, what we do is every 2 weeks, we deposit data on individuals who have a positive COVID test. And of course, nowadays, it's less because many people are positive by their own antigen study. But we deposit that, and we also, because we can get the swab from these individuals for the positivity, we also can contribute to the N3C database for sequencing of the virus. And when you hear that now the newest variant of Omicron is 80% in the Northeast, the reason they know that is because we're contributing sequence data, and it's not us at MaineHealth, it's through this collaborative agreement we have with the Jackson Lab. So JAX sequences much of what the CDC reports to the federal government, and they also provide the sequence data to N3C. So it's a really tremendous collaborative venture. And, we're so thankful to JAX that have the resources, and they've been doing it without additional funding from us. So that's the N3C collaborative, and I'll show you some of the data. In fact, we just published within the past few weeks in the Journal of Rural Health the fact that we were able to access over 1 million COVID patients from 44 US hospital and health systems between January 20 and 2021. And again, rurality was determined by RUCA codes. And as you can see, that the survival estimates, if you read as you go lower in this curve, this is a Kaplan-Meier curve, if you go lower, you have greater mortality. So the brown represents urban areas, and the green and yellow the yellow represents non-urban adjacent areas, which is rural, and the green is urban adjacent. And what you can see is, so you would think about Portland. I live in Freeport. That is an urban adjacent rural area because it's along the coast and it's not in that RUCA code as you remember the picture, but non-urban adjacent areas would be further inland and to the west. But you can see the survival estimates for COVID positivity are much less in the individuals from rural areas. And also, this is very recent data, hot off the press. Rural individuals tend to have a greater likelihood of developing reinfections. So some of that obviously is socioeconomic, some of it is political, but clearly rurality, being tagged with rurality, means that you're more likely to suffer some of the consequences. And it holds not only for COVID-19, but for many other conditions. So what are we doing? I already showed you N3C. So what are we doing at MaineHealth to sort of bring people into research studies? And what research studies are we really involved in? And I was going to focus on COVID because that's so topical. But we're doing a lot of other studies. I'm doing a randomized control NIH study of the use of atenolol to prevent osteoporosis. This is a repurpose of a common antihypertensive drug. We currently have 60 enrolled. We're on our way to 150 individuals to study along with the Mayo Clinic. Very exciting study. If we can use a pretty benign drug to treat osteoporosis or prevent it, it's certainly helpful. But I'm going to focus on some of the data from N3C and also some of the newer initiatives we're after. So this is work that was just published from Kathleen Fairfield and myself. Kathleen is a clinician scientist at Maine Health, and she has done a lot of work on immigrant populations. And in Portland, we have a huge percentage, about 10% of our population is new Americans. And these individuals often have no jobs. They have difficulty accessing care. And Kathleen has been a huge advocate and principal investigator for a study called RADx-UP, which is from the NIH to study vaccine hesitancy in these underserved populations. But this is an evaluation of everybody in the N3C database as of last year that received vitamin D as a treatment for for acute COVID infections. And it was rampant that vitamin D was on the internet as a major way to prevent infection, to treat acute infections, and to prevent long COVID, none of which proved to be true in our study, in which we looked at those that got vitamin D during hospitalization and showed that if anything, those individuals were sicker and at a higher rate, longer length of stay, and greater risk of ventilation and death, primarily because they were more likely to be sick, and therefore people wanted to do everything they could to treat these people. But there was no evidence that vitamin D prevented COVID infections or treated it. Our biggest study to date, and we currently have 110 individuals recruited, is the RECOVER study. And the RECOVER study you may have heard about or read about on the web. $1.5 billion were appropriated to study long COVID in the United States through the NIH. And they were focused on trying to understand the clinical spectrum of long COVID and who recovered and who didn't, and why those individuals didn't recover and how that occurred. And these were the key scientific goals and questions for long COVID. And when this started, when they first passed in early 2021 Congress, and then started up, it was really an attempt to rapidly improve our understanding and ability to treat and prevent long COVID, or post-acute sequelae of COVID, which is called PASC, and that's the scientific term for long COVID. Unfortunately, the term rapidity doesn't work well in the government NIH process. So it took us just about a year to recruit our first subject. We were one of a number of sites that were selected and funded to recruit individuals who were acutely infected and follow those individuals for long COVID. This is the groups of states. We've now enrolled close to 14,000 adults in a 4-year longitudinal study in which the individuals are seen every 3 to 6 months. They have lab works, some of them, many questionnaires, a lot on social determinants of health. Some are asked to come back for further studies like CT scanning and cardiac echo. And the idea is to identify those individuals who go on to develop COVID, what the reason for it is, and potentially the treatment. So, as I said, there's a case identification. We screen all these individuals. We do antibody studies to determine whether they've had acute COVID if they don't know that they've had it, which is not an uncommon scenario. Physical exams, psychosocial history, cognitive assessments, EKG. It's a fairly extensive categorization of individuals. So you can imagine people comes in, we have a research center, they walk in dedicated fully to this study, and they're interviewed, they go through a computer-based questionnaires, they have their blood drawn, they have other phenotypes assessed. And then some individuals get these other tests, and that's randomly selected from a computer-based system at the Mass General, in which certain individuals, because they've answered in a certain way on these questionnaires, are asked to come back for lung studies, for specific blood work, or for MRI. And so what we have is a group of individuals now, almost 14,000. Some have had acute COVID, some are controls that have had no COVID whatsoever. But now that's getting less and less. Probably 95% of individuals, whether they know it or not, have been infected with SARS-CoV-2. And then we have a post-acute cohort. These are individuals who have had acute COVID and now are being followed after their infection. And these include the number of people who have long haulers, long COVID, whatever you want to call it, where they have tremendous symptoms. We also have a group of individuals who've had acute SARS-CoV-2, but do not have any symptoms. And that's a really important control group, because what we want to know is, why don't these people recover, or why do those individuals who don't have symptoms recover fully? And you can see the array of testing that goes into this. So at the beginning of this, myself and Sally Hodder at West Virginia formed a network within the larger RECOVER study, and it was called the Iscore Network. And what it was a band of a group of us who already have a lot of NIH funding to build clinical research infrastructure called Clinical Translational Research Networks, and to bid with the NIH to form this network so that NIH could then feel comfortable about recruiting from rural communities and communities of diverse color and ethnicity. And so these 12 states that have these networks join together. Myself and Sally Hodder oversee the Iscore Network. And we've now recruited, including the Maine 100, we've recruited over 1,100 participants in our hub site. We are the top recruiting network within the large Recover program. And this is our advertisement for getting people to come in and get involved. And we're close to finishing this part of the study in terms of recruitment. But a shout out to the many individuals at Maine Health, part of our research team, who have been involved in doing this really large and extensive project. So the great thing about the Iscore Network is that we share a lot of ideas. And in Mississippi, down there in the bottom of the United States, there's an investigator by the name of Galen Marshall, who has been working a lot on complementary types of treatment for acute infections and for chronic infections. And he came up with the proposition because he's been studying this one product. It's called a natural product derived from Spirulina cyanobacterium called Immulina. And this has been on the market in the alternative sites and also on the web, but also in natural food stores as a boost for immunity. And he's been working with us, and he has approval from the FDA to use this agent in a number of different infectious diseases. What it does is it increases a couple of the important proteins that are necessary to regulate the immune system, including gamma interferon, alpha and gamma, and it boosts our own ability to enhance our killer cell activity. The certain T cells are able to kill bacteria and infections and viruses. And so he had a study already ongoing looking at safety. And so he applied to the NIH for a small pilot study to test whether Immulina might be a useful treatment for long COVID. So I should tell you that the current theories about long COVID, there's three major theories. One, that the virus lives on in those individuals infected, and it sits in certain depots, probably fat tissue, and just sits there and continues to drive an inflammatory response. The other theories are that the antibody production that's generated from this infection persists, and that can then cause its own problems due to chronic inflammation. And the third mechanism that people have been thinking about is related to post-viral infections that have persistent complications. And when referring to that, we think about chronic fatigue syndrome and the possibility of that being a model for what happens with long COVID. The symptoms are very similar to long COVID symptoms. And so nobody really understands why this happens, but it's usually post-viral. And so this represents another hypothesis that's being tested. So we're recruiting into 12 individuals in Maine and around these 12 states, and we're going to treat with Immulina in a randomized placebo-controlled trial at 2 doses for 2 weeks, for 4 weeks for 8 weeks, to see if we can get improvement, not in the symptoms, but in some of the measures of the immune response. I should say that you probably are familiar with Lyme disease and the post-Lyme infection, where you actually get the disease after you've been bitten and you're infected. is very reminiscent with the fatigue and the malaise and the brain fog that we see in long COVID. In addition to that, there's a very exciting national initiative to study patients with long COVID with the use of Paxlovid. And Paxlovid, as you know, is an antiviral that's been used to treat patients with acute COVID. Some of you may have taken Paxlovid, and if you've had, you understand it's pretty safe, although people have occasionally had side effects. But the idea here is a national study of 10,000 individuals with long COVID versus controls treating with Paxlovid to see if their symptomatology and their markers of inflammation are reduced when Paxlovid is given for 8 weeks. And finally, a very recent study of Ampligen, which has been approved for the treatment of chronic fatigue syndrome, is an intravenous drug that also boosts the immune system and inhibits tumor cell growth, is available and will be in a randomized trial. So we're participating in all these individual studies, an attempt to speed our improvement in trying to treat individuals. So the study I want to really pitch to you, and one of the last studies I want to talk about, is called All of Us. And All of Us is a large study. Some of you may have heard of it. It's been going for about 5 years, has 500,000 individuals recruited, everybody, sick, healthy, young, old, anybody can join. Once they join, they fill out questionnaires. They also get their blood drawn. They get genetic testing if they want it. You get your ancestry, you get all your blood work free. You get to know what your status is. You know if you're allergic to medications or if you have a genetic predisposition to allergy to meds. They have 35 different genetic conditions they can test you for, and you can get the results. So it's like 23andMe, although it's provided by the federal government, and it's really an exciting project in which there's sort of bidirectional discussions. So both you and the NIH work together to get a sense of who you are and what your genetic makeup is, what your laboratory studies are, and what your life is all about in the form of questionnaires. So we've been asked by Mass General Brigham and Boston University to be a site for their follow-up study called All of Us New England. And we're hoping to recruit about 300 individuals from rural areas in New England, particularly in Maine, that would allow us to participate in this really exciting study. And what NIH found, and what we've known for a long time, is rural sites don't get picked to be involved in some of these large studies. And so I think as our profile has grown in the state of Maine, and they understand that we can do these studies and do them well, and they're very complicated studies, and they require a lot of work on the part of individuals who are doing this study, that we can offer this to people in the state of Maine. I'll finish with just very quickly. I have a new study that trying to understand whether the virus is hiding in fat cells. And we've put together a small consortium of the group from Louisiana, Kentucky, and Maine to study how the virus, if it does persist in fat tissue, what's it doing there? And is it shedding into the circulation? And is this part of the reason individuals, particularly obese individuals, who are more prone or more susceptible to long COVID? So I think I'll finish there. This is highly technical scientific stuff. So I'll just summarize and say long COVID, we still need a long full definition, but viral persistence is important. Immulina is a potential new therapy, as is Paxlovid, as I mentioned. And I think with that, I just gave you a potpourri of clinical studies that we think are, going to help engage Maine people in this process. And we have a community engagement board that helps us listen to what Maine people want and what they need and what communities are all about. So with that, I think I'll stop and answer any questions.
That's fantastic. Thank you so much, Dr. Rosen. It's really fascinating. I may ask you, you may or may not want to not share your screen. You may want to go back and refer to some of these slides, but I would encourage everyone maybe to turn your cameras on if you want to participate in our conversation. And, feel free again to use the raise hand feature. We'd be more than happy to call on you. You can turn your mic on so that you can ask your own question. I have a bunch of my own that I, sort of was thinking about as you went through your presentation. And I guess, the first one is, I'm curious what you think in your experience of doing this for a fair bit of time, where you see the real advantages for, citizens in places like Maine and other rural areas to participate in these kinds of studies. What do you see as kind of the big takeaway from focusing on these rural areas? Do you think there's something that we can contribute to the understanding?
Yes, so I do. I mean, I think we don't understand. I show you all these graphs that show the rurality is an increased risk for a number of different disorders, and we don't understand the mechanism at all. Clearly social determinants of health are really important. Isolation's important, alcoholism, car accidents, a lot of things that contribute to mortality and increases in chronic diseases. But there's more to it. There must be something within the system that can't adapt as well in rural areas, or is it all environmental? And I think that's the challenge for us, is to try to understand what is it about rurality that's so important. One thing that we noticed is that when people were transferred to Maine Health during acute COVID pandemic, especially last year, the rural individuals were sicker, so they're seeing less care, and by the time they get care, it's often a little late, and they become much sicker, and almost certainly that's the case for a number of different disorders, that the delay in care or the lack of providers in rural areas make it even harder. We're just engaged in this huge healthcare shortage. I mean, I just read about Eastern Maine and what they're trying to do to save some of the systems that they have in place by collaborating with outside groups. And it just, people, it's very hard to get people to practice in rural Maine, and that almost certainly contributes. We have a site in Norway in Western MaineHealth, and we're doing a lot of studies out there in people from Oxford County. And what we find is it's very difficult to get providers to locate out there, and they feel a sense of isolation, and it's too hard. And so MaineHealth has opened up a rural residency program in internal medicine, where they have one resident a year that goes to Norway and trains with the docs there. And we need to do more of those and think a little bit more outside the box to try to understand how we can more equitably distribute healthcare resources to rural areas.
So there are a couple of comments and questions in the chat. I mean, actually directly related to what you were just talking about. Number one, the lack of providers in these rural areas and the challenges that presents, but also a specific question about recruitment from Aroostook County and kind of the more remote or northern section of the state. How does that work? How are you reaching people? What are the mechanisms?
Very difficult. It's word of mouth primarily. It's a long trip down. What the great thing about all of us, that's one of the reasons we wanted to do all of us, was because we can do that remotely. We can send them information. They can sign up. They'd never have to drive 6 hours to get to Southern Maine. We were thinking of doing that in the Recover Project for long COVID, but one of the problems with long COVID is the inability to do those kind of things. So just the kind of people we wanted, we couldn't get because they can't drive. We've had a few people drive 2 hours, but then they have to come back for CT and some of the other studies, and that makes it very difficult.
I can see.
So we're trying, all of us, we hope to reach Aroostook County. And again, We pay for their participation. We try to do everything we can to encourage rural people to enter into the study. But it's a challenge.
That's cool. I can imagine. I see here, Jane Disney has a question. Jane, if you want to unmute yourself and ask your question, go ahead.
Hi, Jane.
Hi, Cliff. I have a question for you about long COVID hanging out in fat cells.
Yes.
Have you heard of any increase in incidences of liposarcoma as
No, I haven't heard of it, but that's an interesting question. I think it's still a little early. But we've been working with a group at Stanford, Catherine Blish and Tracy McLaughlin. And so we all competed for this grant, and it's funny, they got it and we got it. There were only about 18 institutions that got it. And so we decided to share resources, and we're going to look at that, and we'll be looking at RNA and bulk RNA-seq, and also looking to see if there are certain patterns in fat tissue. Interesting thing, Jane, is that if primarily in subcutaneous fat, not in visceral fat, as you might predict. And that's in its own right. That's so interesting. So,
well, yeah. I do know some frontline workers in the healthcare industry who have liposarcoma, and it came on pretty fast. There wasn't a delay. And what I'm going to tell you is that they don't live long. And so I think you're going to miss your opportunity to study these people.
Yeah. Well, that's a good point. I hadn't thought about that. So it's definitely worth thinking about and looking at these people. So we're doing fat biopsies on Maine individuals, and hopefully we'll be able to look and see histologically as well, Jane.
Thank you, Jane, very much. That's great. So there are a couple of other questions here. One comment about our sort of love affair with vitamin D. I don't know if you can see it there in the chat, Dr. Rosen, but just noting that.
Love affair. Yes, we should stop. I've been saying that for years, and I've been castigated in the community of scientists and clinicians. And whoever wrote that can look at the July 28th edition New England Journal book. Cummings from UCSF and myself wrote a glaring editorial, which basically said it's time to stop treating everybody with vitamin D for everything. The proportion of people who really are deficient is really, really low. And it doesn't work in other situations.
This is Dr. Besrab. I'm the one who left that message.
Great.
That's great. So, Dr. Rosen, talk to us a little bit about resources, because, rural areas are notoriously sort of, as you mentioned, kind of the last to receive a lot of these resources. I mean, certainly when we look at the National Research Enterprise, rural areas are typically left out. And I know that you've been very engaged and involved in working with NIH to try and at least rectify a little bit of that. But just, do you see a time when this will become a greater priority for NIH? Do you see more resources coming?
Yeah, let me just share my slide for a second, because I'll address that question pretty directly. So we need resources in rural areas to do these kind of studies. So if you remember the Iscore Network, this is 6 years ago, we were asked to apply Maine Health and the University of Vermont in a collaborative arrangement called the Northern New England Clinical and Translational Research Network. We applied for a $20 million grant to build infrastructure in rural New England, build research infrastructure. And we started, it's an overwhelming task, as you can imagine, particularly in these rural areas. But these other states that also have this $20 million grant, the IDEA states, we call them IDEA states because they're in the lower third of NIH funding. So to be eligible to get one of these research networks, you have to be in a state in the lower third of NIH funding, which we are, the state of Maine. I think we're 40th or something in NIH funding, or a little less than that. But anyways, and in that project, we have started, and we just got it renewed for another $20 million just 6 months ago, to really build out research infrastructure. But I can tell you that one of the biggest problems we have is that we want to listen to the community more than we want to helicopter in and say, you should be doing this, this, and that. And so we started very small in Norway and in Rockland, and we asked the community to help us tell us what they want. I mean, not just that they want to participate in research studies, but what are the issues that really affect your daily life, and how can we apply research options to sort of help that? And so our first rural community, Norway, we populated it with nurses and clinician scientists who just listened. And what we found, and we were surprised, we thought it was addiction was a number one concern, and that's up there, obviously. But adverse childhood events was their number one concern. And so we started to build, through this bootstrap program, a way to address adverse childhood events and work through the school system to try to do that. Now, that isn't fancy pants research where they're coming in for CAT scans, but it's important research because it details what communities want. And so our biggest caution, especially for me, is not to go in there and say, look, this is what you need, this is what we're going to do for you, but rather tell us what you want. And they want to be involved in studies, but we need to have the infrastructure in place to do that.
Yeah. So speaking of infrastructure, there's a great comment in the chat about, this idea of access to the internet. And even in terms of limitation to participate in these kinds of studies, like where do you see that? Do you see that really changing people's ability to participate? And
so I do. I think that's a huge issue, and we think that the IRA bill is going to help that. And Janet Mills is very committed to trying to bring more internet services. Her sister Dora is our medical officer and has been very helpful and instructive in telling us where we should go on that. So yes, it is necessary. So for example, when we do pretty sophisticated cognitive testing, they have to work off a portable computer in our research laboratory, the individual participants. If you don't have access to the internet, you can't do it at home. You have to come in, and that's where the issues come in, driving, and if you're sick, why would you do it? So yes, I think that's an outstanding point, and that's something that really has to be addressed more fully. How do we build infrastructure within the state? I think we're lucky in that we have a commitment now at the state level and certainly at the federal level to bring more internet.
Sorry, I was going to say, I think that will really change a lot of different, access to a lot of different things. So I think that's a really important initiative. I don't see any other questions, but I would say to you, maybe in our last question is, you have an audience here of about 50 people. How can we help you spread the word? What's the best thing? Is it just word of mouth, or are there specific things?
I think word of mouth for now. I think as we come into all of us, I'll come back to you guys with insights, because we really would love to target down east. And this is the kind of study that people can do at home. And they can get their blood drawn locally. And so we would love to engage with the community in northern and eastern Maine. We're a little tapped out in southern Maine. I think we've gotten close to where we've reached people, and I think we need to do more in the northern and eastern sections. I can't provide Sister Norberta again, but we can provide some other opportunities for people. And it's fun to be involved in a research study. It's fun to have some camaraderie with other people. I'm going to be one of the first ones to join. I want to know, some of my genetic stuff. I want to know about how my social determinants of health affect what I'm doing. So yeah, it's just, and it's all the medical record transfers are really all such that they're de-identified. So there's never a risk that your information will get outside of an institution or outside of your
I was going to ask that, wondering if
Yes.
that was part
No,
of
they so one, we have this tremendous security system in place that's leveled by both West Virginia and NIH. So there's 3 levels that you have to go through. So everything is de-identified, and it's centered actually at the Mass General. And they've been working on these processes for several years, and it's pretty transparent that that there's no the only thing, there's no zip codes, there's no personal identification, there's no addresses, there's no phone numbers, there's none of that. It's just you as a person. So.
Fascinating. There's a suggestion in the chat about maybe posting information on these studies in the local sort of primary care offices and the ERs and that sort of thing.
So that's a great suggestion. And one of the things that we've done very successfully that's been modeled elsewhere is use letters from physicians to their patients. So for osteoporosis, we know from our electronic health records who has low bone density, for example. And so in a group practice of maybe, 5,000 people, maybe 100 have low bone density. Well, we can ask our physicians to sign off on a letter that says, we'd like to have you involved in a research study. And the doctors really like that because they're instrumental in helping, or the providers, in helping us get individuals, and also being a member, being part of the research study. So
yeah. Oh, that's terrific. So one question is, when is too old to participate? Are there
there is no upper age limit, which is great. So
well, this is really fascinating, Dr. Rosen. It's kind of the first time I've thought a lot about these, ongoing research studies. And I think, we'll do our part to try to spread the word and encourage people to participate. I'll sign up. I think it'll be a fun.
All of us will be fun.
That's fantastic. Well, wonderful. Well, thank you so much for spending some time with us this afternoon and for sharing all this great information. We really appreciate it. And thanks to all of you in the audience for your participation and for tuning in. As I mentioned, we're really excited about the upcoming year. This is our 12th season of offering science cafes, and it's really due to the generous support of all of you for allowing us to continue these programs. So a huge thanks to each of you for that. Our next presentation will be February 13th. And, as we're talking about sort of rural states like Maine, we know there are a lot of challenges, particularly as we look toward our workforce. We have this very aging population, as Dr. Rosen pointed out. And there really is an intense effort underway to make sure that Maine has the kind of technology-focused workforce that it will require in the future. And so we're putting together a great collaborative presentation that focuses on folks from the Jackson Laboratory, from the Rue Institute, from here at the MDI Biological Laboratory. So we hope you'll tune in. It should be a really lively and interesting conversation about what the future of Maine's workforce looks like. So thanks again, everyone, for tuning in. And it's great to see all of you. And we'll see you next month on our next Science Cafe. Take care.